Are you're not seeing my screen right now, are you?
No, please try sharing again.
Because I didn't stop.
It's back up. Now we see your screen.
So it seems like we don't have anybody joining at this point. I assume we'll still go ahead if nobody's joined.
Yes, let's go ahead and join and get a good recording with interpretation service from ASL this time.
Mhm. So I think we should probably get started. It's currently 5 p.m. Pacific, 8 p.m. Eastern. And I'd like to welcome everybody to this Anchor Study Virtual Town Hall. We will be discussing the results of the study, future steps for the study, and take questions and answers. So again, welcome. Thank you so much for participating. A few things to note before we actually get started. First is you may notice a set of choices on your screen to tell us who you are. We would really appreciate it if you could check one of the buttons so that we know whether you're, for example, a current or a past Anchor study participant, someone from the community, a medical professional. This information is being collected anonymously, but we would appreciate it if you could select one of those categories. And once you do so, that part of the screen will disappear. The other thing is that we are very fortunate to have both Spanish translation and ASL interpretation. To access the Spanish translation, you will need to press the button on your Zoom bar for the translation services. So if you would like to have the translation, please make sure that you are pressing the interpretation button on the Zoom toolbar. I'm going to give you a few seconds to press that if you wish to access it. And we will be having ASL translation from Becky. So the format for the next hour or so is that I'm going to do a presentation, which shouldn't last more than 20 or 25 minutes. I'm going to do a few introductions, provide a little bit of background on anal HSIL, that's high-grade squamous intraepithelial lesion, the anal cancer precursor, and also some background on anal cancer. Talk about the results of the ANCHOR study, and then talk about the implications for those results for your clinical care and some additional questions that we're going to want to address because of the results of the ANCHOR study and some future studies that we hope you might be interested in participating in. We will then take some questions and answers and summarize where we are. This is actually the fourth of a series of town halls. We've been very fortunate to have a number of great panelists. I'm your host today. I'm Joel Polewski. I'm the protocol chair of the ANCHOR study and am based at the University of California in San Francisco. We've also been assisted by the protocol co-chair, Hilary Dunlevy from the University of Colorado and Isabella Rosa Cunha from the University of Miami. And we're very, very fortunate to have a number of community liaisons and community advisory board participants. Bill Freshwater is actually joining us tonight. So thank you so much, Bill, for doing so. And we've also been joined in previous town halls by another important CAB member, and that's John McFeely. So before we get started, a very important part of this town hall is to have the opportunity to answer any questions that you may have. To ask those questions, we'd like you to use the Q&A function, the question and answer function, which you can see on this slide here. This is where we would like you to type your question in. You can do so at any time. You don't have to wait until the Q&A period has started or I've finished my presentation. So please do enter your question there. If you want to answer or ask your question rather in Spanish, that's fine. It'll be translated and I will answer it in English and the answer will be translated as well. We are trying to keep everything as anonymous as possible. And when you're asking your question, one thing that you probably should do is to ask the question anonymously. There's a little opportunity for you to do that. If you don't do that, the question, your name will appear with the question, but only to the panelists, and your name will not appear to the remainder of the attendees of this meeting. So it will still be anonymous, and so you can be sure that anything that you ask, your name will not be associated with that. But please, when you're asking the question, check off the Ask Anonymously button if you can remember to do that. If you do have any other questions that haven't been answered by this town hall and you want to talk one-on-one with anybody in the ANCHOR study, we recommend that you contact your local study team if you are an ANCHOR participant. And if you're watching this presentation live or a recording of this presentation, then feel free to contact us at the National ANCHOR team via our study website, which you can see here, which is www.anchorstudy.org. So this presentation is both live and being recorded and will be accessible in the future if you wish to watch it or recommend it to another person. So with that, I'd like to begin by providing a little bit of background on why we did the anchor study, on what anal HSIL is, and what the problems are with anal cancer. So firstly, a very basic question: what is the anus? The anus actually is a very specific part of the gastrointestinal tract. It's the very end of the GI tract where the rectum approaches, and then the very end after the rectum is the anus, which is the area from the end of the rectum all the way to the outside in a circle, a radius, if you will, of about 5 centimeters from the opening of the anus. So the anus is actually kind of two organs in one. It's the inside part here, which you can't see, and then the outside part, which is the skin surrounding the very tip of the anus. And the important thing here is that, firstly, the areas that we are most concerned about are where that anus meets the rectum. So all that is invisible. So we need to do a lot of different kinds of tests to see what's going on there. But although this is the most common area where people develop anal HSIL and cancer, anywhere in the anal tract can be an area for anal cancer, all the way from that area where the anus meets the rectum to the outside part of the anus, that what we call the perianal region. All this area is, of course, kept closed. That's the reason that you're able to decide when you want to have a bowel movement by a muscle called the sphincter muscle, shown here. And when we are putting a swab in, for example, to do a test or a scope, some of the discomfort that people feel is because we're trying to get past that muscle, the anal sphincter. So we're going to talk about three things: the virus that causes this entire problem, which is HPV, human papillomavirus. We're going to talk about anal HSIL, and we're going to talk about anal cancer and how cancer is different from HSIL. So HPV is a very common virus. There are many, many kinds of HPV, over 100 different types, in fact, and they cause problems in many skin surfaces. So a lot of us have had warts on our hands or feet. That's due to HPV, but not the same types that cause problems in the anal canal. In the anal canal, we can get different kinds of problems, ranging from genital warts, which are a serious problem, but they are not dangerous from the point of view of being precancerous or having the ability to progress to cancer. So they're very, very annoying, to say the least, but generally will not cause serious health issues as far as cancer is concerned. But HPV can also cause precancer or HSIL, and some people who get precancer can progress to cancer. The thing about HPV, particularly the genital HPV types, including the ones that infect the anal area, are so common that at some point in time, we think that more than 80% of all sexually active adults will have at least one HPV in their genital area, possibly including the anus, at some point in time during their lifetime. So in fact, it is the most common sexually transmitted infection. So HPV being that common, we also know that most people who get HPV infection never have a problem with it. However, some, and in the case of people living with HIV, a fairly high proportion do develop a problem called anal HSIL, which is the cancer precursor. Some of these can go away by themselves, but some of them do require treatment to make them go away. And the key thing about these is you see all these round cells here sitting on top of the floor, which we call the basement membrane. This is the base of the skin, the floor of the skin. HSIL, since it's not cancer, never pierces that bottom. I'll show you in the next slide what cancer looks like, because basically the difference between HSIL and cancer is that with HSIL, these cells stay where they're supposed to, but with cancer, they pierce the basement membrane and go underneath, and they reproduce, and the masses that develop as a result of that can cause serious problems, such as blocking organs in the pelvic area, or even spreading to other organs far away from the anus, like the liver or the lungs, where ultimately each of these problems could potentially result in the death of the person. So the difference between anal cancer and anal HSIL shown here. You can see all these cells sitting on top of this floor, but with cancer, now they're piling up and going through the floor down below into the tissues where they can cause some serious problems. Now, the problem with cancer is that when it's caught early, people usually survive, but the treatment can be quite nasty. If the cancer is caught later after it's spread, the treatment sometimes, not infrequently, actually doesn't work very well, and the person could potentially die of the disease. So how common is anal cancer in people with HIV? So people with HIV are actually amongst the highest risk group of all. We estimate, based on numbers from various studies, that the lifetime risk of a man who has sex with men living with HIV, the group at the very highest risk of all, could be as high as 10%. So if you're a man who has sex with men and you have HIV infection, you have potentially a 10% chance of developing anal cancer at some point during your lifetime. That is both good news and bad news. That means that 90% people won't, but 10% is a very high number when you consider the bad consequences of getting anal cancer. It's much, much rarer in the general population, and interestingly, tends to be more common in women in the general population than in men. So again, we want to prevent anal cancer whenever possible, because if we wait for anal cancer to develop, even when it's caught early, despite the good survival, because of the treatment that's needed for most of these, particularly radiation, the person might have a very bad effect on their quality of life. And then if the cancer is caught later, they not only have to undergo the same radiation treatment, but may have bad survival because of the spread of that cancer. So, since we know that anal HSIL can progress to cancer, we think that it may be possible to prevent the cancers by looking for and treating and removing the anal HSIL before it has a chance to progress to cancer. So how do doctors screen for anal HSIL and cancer? Typically, the very first step is shown here on the left, where we put a swab inside the anal canal and collect cells from the lining of the anus and look at them under a microscope. This is called cytology, and some people also call this a pap smear. Sometimes these cells show signs of problems in the cells caused by HPV, and that might prompt the doctor or clinician to send their patient to somebody who's specialized in some of the next steps of the evaluation that I'll be discussing. In addition to collecting cells, we can also use this sample to test for HPV itself, and that's something that more and more people are doing nowadays. The other thing that we want primary care providers to do, in addition to taking these kinds of swabs, is to do a test called the Digital Anal Rectal Exam, or a DARE, where we ask people to put a gloved finger inside the anus after putting some lubrication on and feel around for any lumps. It's not uncommon to feel lumps in the anal canal, but when a person has cancer, that lump is often hard, and it's kind of obvious that this person may have something serious as cancer. Almost all clinicians know how to do a rectal examination, and so we recommend that clinicians, after they do the swab first, because you have to do that first because you cannot put lube on this swab, do a digital anal rectal exam after doing the swab test. If either the results of the swab test are abnormal or the clinician feels something that they're suspicious of, then the person may get sent for the next step in the evaluation, which is called high resolution anoscopy, or HRA for short. So here's what happens when somebody's getting HRA. The clinician puts lube on a small plastic anoscope and inserts it into the anal canal. They do a bunch of other tricks to help the abnormalities caused by HPV, the potential HSIL lesions, to show up more easily by applying solutions like vinegar, 5% acetic acid, or an iodine solution. And if they see areas that look suspicious for HSIL or cancer, then the clinician needs to take a sample of it to look at under the microscope to prove that it's either HSIL or cancer. And to do that, we take a tissue sample called a biopsy using an instrument like this. It's called a forceps. And the piece of tissue is quite small, usually about the size of a sesame seed. That tissue is then preserved and then looked at under the microscope by the pathologist, who will tell us whether it's normal or high-grade disease or cancer. So obviously, if the person has cancer, they need to be treated for cancer. But if we find high-grade disease, again, one option is to try and remove it before it can progress to cancer. And there are different ways of doing that. The most common is what we call ablation, where we put the scope in and find the same lesions that we saw before. And now we apply an instrument, could be an instrument that provides heat or electricity. The latter is called hyfurcation. So when we touch the area of the HSIL with the heat instrument or the electricity instrument providing electrocautery, it basically destroys that area very specifically where the instrument is touching the tissue. We do that because we want to destroy the HSIL as much as possible, but we don't want to destroy normal tissue. So we try and spare that as much as possible. Another approach that some people use occasionally is to ask the patient to apply creams themselves, which they can insert into the anal canal or apply on the outside, that covers large areas of tissue with a cream that has some ability to destroy both the HSIL and hopefully as little of the normal tissue as possible. But the approach that the doctors and other clinicians use the most is the ablation, and most typically with electrocautery with a technique called hyfurcation. So now let's turn to the anchor study itself. We did the anchor study because we know that there's another cancer, cervical cancer, and women typically go through screening procedures like I just described for cervical cancer by getting a cervical pap smear. And we know that if they're diagnosed with cervical HSIL, it is very effective to reduce the risk of cancer by treating the cervical HSIL. And we know that cervical and anal cancer are very similar. And so we always asked, why not look for and treat anal HSIL to reduce the risk of anal cancer, just like we do in the cervix? The answer is that we haven't done that because we didn't have the proof that this actually worked. We are in an era of what we call evidence-based medicine. We like to know that things work before we subject our patients to them. And so a study was needed to show whether treating anal HSIL actually reduces the incidence of anal cancer. Nobody had ever done that before. So we did the study called ANCHOR to find out if it works. And the only way to do a study like this to generate the kind of high quality evidence that we needed was to do something that we call a randomized controlled trial, where we try and make two groups that are very equivalent and compare a treatment group. So we find HSIL and treat it to people who have HSIL, but who weren't treated, to show whether or not the treatment had any effect on the rates of cancer. So the ANCHOR study, and ANCHOR stands for Anal Cancer HSIL Outcomes Research Study, was performed at many different sites because it was a big study You can see the sites here. Many of the places where we did these studies were in places where a lot of people living with HIV live, because the study was focused entirely on people with HIV, since this is the group, as I mentioned, with the highest risk of anal cancer. We ended up following 4,446 people with anal HSIL. And to find that many people, we actually needed to screen 10,723 people. So we screened this group. They had to be 35 years or older. And if they had anal HSIL after undergoing the anal swab test and the HRA and the biopsy, and they met all the other study criteria, then they were enrolled in the study and divided 50-50 into the treatment versus what we call the active monitoring group to allow us to compare the effect of treatment. So we actually found 4,459 such people, but a few people dropped out before we could follow them. And so we ended up following the 4,446. We also found 17 people at that screening visit who already had cancer. And so these individuals were obviously not enrolled in the study, but referred immediately for treatment of the cancer. So amongst those 4,446 people, they were divided roughly 50-50 into the treatment arm versus the monitoring arm. People were followed every 3 to 6 months generally, getting their lesions treated if they were in the treatment arm, or being followed carefully in the monitoring arm and biopsied anytime there was a concern for cancer. And when all was said and done, we found that 9 people in the treatment arm developed cancer, 21 in the monitoring arm developed cancer. And so you can see there's an important difference. 2,228 continued to have HSIL in this group, and 2,201 did not progress to cancer. Neither in either 2,228 didn't progress in the treatment arm, and 2,201 did not progress in the monitoring arm. So who was in this study? Basically, it was a group that kind of closely resembled the overall composition of people living with HIV in the United States. We had about 80% being male, 16% were female, and about 4% were transgender. We had about 42% African American, 32% were white, and about, I can't see this here exactly, a substantial number, I think about 16% or so, were Hispanic, non-African American. So we had a very good distribution of people in the study, again, pretty well resembling the overall composition of the HIV population in the United States. So for the people who were in the treatment arm, they had primarily hyfurcation. Some people did have creams. Overall, the study procedures were very well tolerated, and there were thousands of study visits, but only 8 had serious side effects that were caused either by treatment or monitoring. There were 7 in the treatment group, 1 in the monitoring group, but these resolved usually within a few weeks. So overall, the treatment was quite safe and well tolerated. With the 9 and 21 cases in the treatment arm and the monitoring arm respectively, what that translates into is a 57% decrease in anal cancer in people whose HSIL was treated. So what that basically means is that by treating anal HSIL, we can very substantially reduce the incidence of anal cancer. We did not completely prevent anal cancer, but we had a statistically significant large decrease in the incidence of anal cancer amongst people who were treated. So that was really good news. And so based on that, the Data and Safety Monitoring Board, who monitored our study all along, suggested that we stop the study because we proved that treatment works. And We are now offering treatment to everybody who was in the monitoring arm before the study was stopped, and of course, continuing to monitor and treat anybody who was in the treatment arm before. We are really anxious to see everybody who was in the anchor study, even if you haven't come in for a while. We would even love to see people come back in, even if they were in the monitoring arm before and don't want treatment now. We would still love to be able to assess you and follow you. And we will continue to follow everybody until September 30th, the end of September 2024. So we will continue to do study visits through that time and be working with everybody until then to create an individualized plan to help you determine how to continue to get follow-up and treatment after September 30th of 2024. So with the good news that we think we can prevent a lot of cases of anal cancer, there are now a number of national bodies like the Centers for Disease Control who are determining whether the screening and treatment procedures that I've described should become a standard of care, basically being available to everybody. If that happens, we think this will really be great news for the HIV community. We hope it'll expand access by improving insurance coverage, and we hope that it will encourage more clinicians to get the training they need to do HRA and to treat the lesions as well as possible. The study also raises a lot of additional important new research questions, and we need to do more research to figure out, for example, the very best ways to screen for anal HSIL and cancer. And since we didn't prevent all the anal cancers, we would love to get even better treatments for anal HSIL. And so we are actively engaged in trying to perform treatment studies of new ways to treat anal HSIL. Also, since so many people have HSIL, we would like to know if there's any tests that we can develop that tells us that, for example, this person has HSIL and is at risk of developing cancer soon, and so we need to treat them very quickly, versus someone who has, say, a negative test, who we think is at low risk of progressing to cancer and perhaps could be followed less frequently than the first person. We'd like to have a blood test for that, or something that we can measure in a swab or in a biopsy, but this is all research that we are going to be doing, and actually thanks to the people who contributed to the anchor study, because everybody who was in the anchor study provided samples of swabs and blood and tissue that we collected very carefully, which we will use to perform some of these studies. So we're very grateful to the community of people who participated in the anchor study. The study was solely focused on people with HIV, but there are other groups who are at risk of anal cancer. And we also want to try and figure out if the same kinds of things that worked in people with HIV can be recommended for some of these other groups. For example, people who are immunosuppressed for reasons other than HIV. Maybe they had a kidney transplant or something like that. So ultimately, the question you may be asking yourself is, can I stop HSIL, anal HSIL, from becoming cancer? And we cannot guarantee that because we were not successful in preventing all cancer, but we prevented a lot of cancer. And we do believe that it is worthwhile to get screened and treated. So we strongly encourage everybody to continue to get HRA and treatment of their anal HSIL. If you are listening and you are a participant in the anchor study who hasn't been in a while, please, we'd love to see you. And we would love to be able to see whether you still have HSIL and make a recommendation for you. You are, of course, free to go and see another clinician or to continue to participate in anchor-related research. These are all options for you, but we strongly encourage everybody to get HRA if at all possible. One of the other things that we learned in the anchor study is that there are other factors besides HPV that may be playing a role in increasing the risk of progressing to cancer if you have HSIL. One of those is smoking. So the other thing I would strongly encourage everybody to do if you're a smoker is to stop smoking or vaping if at all possible. And of course, good HIV care is always critical. So if you have HIV, to continue to get really good treatment and monitoring for the control of the HIV. So this is also a bit of a plea as well as a thank you again to everybody who contributed enormously to the community of people living with HIV through their generous time and contributions to the anchor study. We are recruiting to some of these other studies that I mentioned. And so if you are offered one of these studies, please strongly consider it. And we still have more to do. Again, I think we got great results with the anchor study, but we want to do even better. And we want to be able to follow people as efficiently as possible with as little interruption to their lives as possible. And again, it was the participation of the volunteers who enrolled in the anchor study and the really active community advisory board at each of the sites on the National Community Advisory Board and the excellent teams at each of the anchor sites that really worked together to help make the anchor study a success and made a really big difference, I think, in preventing a very serious problem that could occur in people with HIV. So to summarize, anchor is a very historic study. For the first time, we showed that treatment of anal HSIL lowers the risk of anal cancer. We think that is important for people with HIV. We hope it also helps other people at risk for anal cancer. And the results of the study are now being used to create new guidelines for anal cancer prevention, which we hope to see over the coming months. But we still have a lot to learn. And again, we want to figure out who is likely to progress to cancer, if we can identify such individuals, and how to treat these lesions better. And of course, we will continue our commitment to share any important information that could affect your care with you as quickly as we possibly can. So with that, I think we will turn it over to our question and answer period. Thank you very much for listening. And again, please feel free to contact us either through your Q&A box now or in the future through your anchor site or on the national website. Thank you for your attention.
Thanks very much, Joel. My name is Julia Pugliese. I'm the Anchor Project Director with UCSF, and I'll be posing the questions that you ask us either via the Q&A or through our website during this session. I'll start up with a question on HPV vaccination. One of our attendees would like to know, I received the HPV vaccination. Can I still get anal cancer?
So the answer is yes. The HPV vaccine was primarily designed to be a preventive vaccine, namely to prevent you from getting HPV before you encounter it. If you already have acquired at least one cancer-causing HPV type, the vaccine may prevent you from getting other types that you haven't already encountered, but it won't do much for the HPV type that you have already had or acquired before you got vaccinated, and which may have caused or could still potentially cause anal HSIL. So the bottom line is that vaccination may be effective. In fact, we have some evidence that it is effective in preventing new HPV types, but it's not going to have very much effect on anything that may have happened before you got vaccinated. So yes, unfortunately, in this situation, vaccination will not necessarily prevent development of either anal HSIL or progression of HSIL to cancer.
Next question. Someone would like to know, does having anal sex cause anal cancer? I only had anal sex a few times. Does that mean I'm at very low risk?
Anal sex does not cause anal cancer. Anal sex may result in HPV infection, which has the potential to cause anal cancer. We also believe that the more partners you have with receptive anal sex, the higher the risk of getting anal HPV. But we also know it doesn't take much. HPV is very easy to spread, and you don't have to have a lot of anal sex or a lot of partners even to have anal HPV infection. Also, anal sex is not the only way to get anal HPV infection. Women, for example, may get anal HPV by having it spread from the cervix or the vulva if they have infection there. And it's probable that men can get spread from their own genitals too, potentially from an infection in the penis or in their scrotum. So unfortunately, even if you've had not very much anal sex, there is still a risk of having anal HPV, but more anal sex means higher risk.
Next question. Someone would like to know, I have not had anal HSIL for several visits. Am I cured if it hasn't been found after several visits?
So cured is actually a word that we don't use very often in the HPV world. We think that many people, particularly those with HIV, may have little pockets of HPV here and there that are dormant or not doing very much, and the clinician doesn't see anything. So it's encouraging. It's very encouraging that you haven't had HSIL for a while, and the longer that you go without having anal HSIL, probably the less likely it is that you're going to develop it in the future. But unfortunately, it does not mean that you're completely out of the woods. And there is still a possibility that HSIL may be found either in the form of a recurrence, meaning in the same area where it was treated originally, or it could even be found in a new area where the clinician didn't see it before and is now seeing it for the first time, even if there's not a new sexual exposure. And that could be because of that dormant HPV infection, which for whatever reason, which we still don't understand well, becomes reactivated.
Next question. Should I continue with anal exams after the study ends? And if so, how do I find a doctor?
So yes, we do believe that you should continue to get followed precisely for the reasons that I mentioned in the answer to the last question. We don't know when somebody is at zero risk for having an HSIL recurrence during their lifetime. So for now, we're recommending continued follow-up. We do hope that if people are not having recurrences, that we can increase the interval between visits. So you don't necessarily have to come every year. Maybe over time, you'll get seen every 2 years or 3 years, but you do need to continue to be seen. So the question is, since we're stopping follow-up in the anchor study on September 30th, 2024, where can you get an exam? My recommendation would be to talk to the clinicians who are seeing you in the anchor study. It's possible that they will continue to be able to see you in their clinics outside the anchor study. Or if they can't, they may know people in your community who are available to do that. I do have to say there is an issue, a problem, because the number of people who are skilled at doing high resolution anoscopy is still quite limited, and it takes a long time to get really good at it. So if and when guidelines are put out that suggest that all people over the age of 35 or 45 with HIV should get screened, we're going to have a lot of people who are going to need some procedures and still not enough people who know how to do HRA. And so we and others are working hard to plan for scaling up training programs so that more people will become available to do this. So at the very beginning, it could be challenging, but I do think that your best resource is going to be your local anchor team.
Thank you. Next question from a participant is, how do I prep for HRA?
Great question. So some people think that to get the best exam, they need to make sure that their bowels are emptied before they come to see the clinician. In fact, here at UCSF, for example, we have a phrase in our own clinic. We say, come as you are. In other words, we don't need you to do anything to prepare for HRA. Two reasons for that. One is that if you do evacuate your bowels before, you're also washing away some of the cells that we're interested in studying to see if there's any signs of HPV when we're collecting the swab. The other is, you remember that anal sphincter that I talked about at the very beginning? That sphincter is there to keep your poop inside until you're ready to evacuate it. And generally, the sphincter keeps everything in the rectum and above. And so it doesn't prevent the clinician from seeing the anus as well as they need to. The anus is not a holding area, it's a transit area. So basically, almost everybody, unless they're having active diarrhea, can have a successful HRA without the need for any kind of preparation.
Next question. Are the study results relevant for HIV-negative gay men?
Great question. So this study was done in people living with HIV because this is the highest risk group of people. We did not study people without HIV infection. And so technically speaking, we still don't have evidence that anal HCl treatment will benefit people who don't have HIV infection. That said, we think it's going to be difficult to repeat the anchor study in any of the other groups, and we may not ever get the kind of direct evidence that we now have for people with HIV. The good news is that we think that the results that we got with the anchor study should be at least as good, if not better, in some of the other groups who don't have HIV infection. People with HIV sometimes have the toughest lesions, toughest abnormalities to treat. And so if we did as well as we did with that 57% reduction in a very challenging group, such as people with HIV, we think our results will be even better in some of the other groups, such as people who don't have HIV infection. And so we think that the results are probably applicable, but it remains to be seen whether the regulatory agencies, such as the CDC, will agree to allow us to extend those findings in the absence of direct evidence. My personal opinion is I think we should, but these will be some ongoing discussions in the near future.
Thank you. Next question. Can anal cancer spread to other parts of my body, and can it cause other different cancers?
So anal cancer, as I mentioned, can spread if it's untreated, if it's never detected early enough. When those cells break through the floor, they can create masses of tissue locally, but then some of those cells can enter the bloodstream or another network called the lymph nodes to spread to other organs, such as the liver and the lungs are some of the most common. And it may be there that the growth of tumors in those tissues actually results in the death of the person. So the cancer can definitely spread to other parts of the body beyond the anus. That said, it will not cause any other kind of cancer. Anal cancer is anal cancer. And so you may have other forms of cancer in the lungs or the liver. You could have liver cancer caused by other viruses, lung cancer caused by smoking. But these are not related to HPV for the most part. So anal cancer can spread, but it doesn't cause other cancers.
We received a related question through the website, and that is, how often do second cancers happen in people who've gotten treatment for anal cancer?
We don't have a lot of good information on that, but there is some suggestion that if you have an HPV-related cancer, such as anal cancer, you are at risk for other HPV-related cancers at other anatomic sites. So, for example, women who have had cervical cancer or cancer of the vulva, vulvar cancer, are known to be at higher risk of anal cancer than women who haven't had cervical or vulvar cancer. Again, it's probably because the commonality of the cause of these cancers, which is all HPV. It's not that clear if men with anal cancer are at increased risk of other HPV-related cancers, but the most clear evidence is in the women with cervical or vulvar cancer.
Thank you. An attendee would like to know, how treatable is anal cancer and what's the success rate?
So the answer to that question depends on when it's found. If it's caught early in what we call stage 1 or 2, the success rate is very high. We express these success rates as survival over a 5-year period, typically. And for these early cancers, the success rate is about 70% or more. When you start to get more advanced cancer, such as the ones that have already spread to the liver or the lungs, then you're starting to get very poor rates of 5-year survival, usually less than 20%. So catching a cancer earlier is better. In fact, there's a really early form of anal cancer called superficially invasive squamous cell cancer of the anus, where we think we might even be able to treat some individuals by just removing it surgically and avoiding the need for chemoradiation therapy, which causes some of those long-term symptoms. So anal cancer is optimally caught as early as possible. Even more optimal is to catch it before it turns into cancer while it's still HSIL and remove that HSIL.
Thank you. Another participant would like to know, is one treatment for anal HSIL better than another?
So ANCHOR was not designed to compare different treatments because clinicians could pick whatever treatment they wanted, but they did have to pick from a menu of treatments, a limited number. Almost all the clinicians chose the electrocautery method, which I described earlier. That's because most of us think that that's the best method. So while we didn't compare electrocautery to other methods, say in the ANCHOR study, what we do know is that most of the benefit that we showed, that 57% reduction in anal cancer, was due to the electrocautery. We also know that electrocautery is quite safe. It's done in the office and results in relatively few long-term side effects. So it's well tolerated, doesn't cause very much pain. Every procedure is, of course, uncomfortable and at least a little painful, but the electrocautery or hyfurcation really is quite well tolerated. So given the fact that we know that it was successful in reducing the risk of anal cancer and that it's well tolerated, most of us feel that some form of ablation, such as electrocautery, such as infrared coagulation or laser, should be the first treatment of choice in most cases. What we tell the doctors and clinicians is use whatever equipment they have. Some of them already had lasers before starting the study or seeing patients after getting trained. And if they have that, that's fine. If they already have an infrared coagulator and they want to use that, that's fine. But if your clinician is deciding on which method to use and has to pick some equipment, we typically recommend the hyfurcator because it's one of the simpler pieces of equipment and seems to work quite well.
Thank you. A participant would like to know, what can I do to make treatments more comfortable?
So it really kind of depends on the treatment that's being done. But if we're assuming, for instance, that the person is coming in for a hyfurcation for the electrocautery, Again, they don't need to do any kind of a prep for that. What we typically recommend after the procedure is done is to take good care of yourself and give your anal area a bit of a rest. So we recommend lots of hydration and fiber to keep the stool soft, because it can be painful to pass a hard stool. So that's really important. We recommend no anal intercourse or insertion of objects for at least a few weeks to try and allow the area to heal. We also recommend trying to reduce a lot of physical stress, no heavy lifting, etc. Again, just to give the area an opportunity to heal and to be quiet. Sometimes pain medications are needed. More often than not, we prefer to use something other than codeine or opiates, because codeine causes constipation and hard stools. Much of the time, the pain can be well controlled, if medicine is needed at all, with Tylenol or a non-steroidal anti-inflammatory. So these are the main things that are helpful in trying to reduce the amount of pain after the procedure. And during the procedure, the clinician will do a few tricks to try and keep the procedure as painless as possible. When numbing up the area with a local injection of lidocaine, typically add another solution called bicarb, which makes the pain injections themselves more comfortable. And of course, they will numb up those areas as thoroughly as possible to make sure that the electrocautery or other ablation techniques being used cause very little or no pain during the procedure itself. Most people don't have very much discomfort during the procedure, apart from the initial discomfort of getting the numbing injections.
Thank you. Next up, someone would like to know, what signs or symptoms should I be worried about for anal HSIL progressing to anal cancer?
Great question. What we teach clinicians to look out for is if a person notices a change. If they notice a new lump, for example, that wasn't there before, if they have new pain that isn't easily explained by some of the common causes of pain, such as an external hemorrhoid or an ulcer caused by a sexually transmitted infection, such as herpes. So there are some common causes of pain, but if these are ruled out, then and the pain is persisting, then anal cancer needs to be ruled out as well. Also, a change in bleeding pattern. Some patients have regular bleeding. It may be from an internal hemorrhoid, or it could be, after passing a hard stool. But if something changes, the bleeding becomes more regular or larger volume, then that should also prompt a visit to the clinician to make sure that anal cancer is ruled out.
Next question. What would you tell a patient who's nervous about getting treated?
I would tell the patient that it's important to know that the people who are seeing them, such as the anchor clinicians, are all highly trained and very, very sensitized to trying and keeping everybody as comfortable as possible. It's not a fun procedure, let's face it. It's inserting a bunch of things into a very sensitive area, and nobody likes that. But with very careful medical attention, use of lots of lubricant, being gentle, appropriate use of numbing injections, the amount of discomfort that somebody has should be relatively little. We'll never say none, because we know there's always a degree of discomfort. But most people who are nervous find that after the procedure is done, it wasn't quite as bad as they were fearing.
All right, we're almost near the hour, so this will be our last question. Someone would like to know, what other studies for anal HSIL can I take part in?
Well, that's also a great question. Anchor was performed as part of another organization called the AIDS Malignancy Consortium, or AMC. Most of the sites that did the Anchor study are members of the AMC, and we are doing 2 studies right now that we would love to have more volunteers for. One of them is for a cream, 5FU cream, to look and see how well that works versus short-term follow-up without the cream. And the other is a very exciting study of what we call a therapeutic vaccine. It's not the same as the HPV vaccine that's out there, which, as I mentioned, is designed to prevent initial HPV infection. This therapeutic vaccine is designed to stimulate your immune response so that it fights off the HPV infection and the H cell that it causes that you already have. And so this is an exciting new approach that we want to test. So that's just 2, but we also have a number of others in the pipeline, and we're hoping to enroll to these studies as much as possible.
All right. We just got one last question. I think it's a quick one.
All right.
Someone wants to know, where does the name Anchor study come from?
Okay, so it's an abbreviation. Anchor stands for anal, A-N, cancer, that's the C, H-cell, that's the H, outcomes, that's the O, research. Anal cancer H-cell outcomes research study. That's where Anchor comes from. So thanks for that question. I'm quite proud of that abbreviation since I made it up. So with that, I think our hour is up, and want to thank all of the audience, those watching on Zoom, those watching on YouTube, those watching a recorded session, for listening to us. Again, I want to extend my deepest gratitude to the volunteers of the Anchor study who really made a historic contribution to cancer prevention, not only in the HIV community, but as you heard, we think that the results will be even more widespread in their use than the HIV community. So you've really made a major medical contribution, and I hope you're very proud of that, because we know that participation took a long time and wasn't always comfortable. And again, I want to thank the Community Advisory Board, who really helped with the implementation of the study, and people like our hostess, Julia, played an enormous role. And it was also very generously supported by the National Cancer Institute. So I think the NIH, of which the National Cancer Institute is one of the key parts, really deserves a lot of credit for their very generous support and encouragement of doing this study. So all of these individuals and groups were necessary to the success of the study. So thank you all. All right, there we are.
Thank you all so much.
Thank you, everybody. Have a nice evening.